This is Dr. Christopher Sendy with Nova Health Recovery Ketamine Infusion Center in Alexandria, Virginia. And I'm going to discuss oral and intranasal ketamine therapy for depression and mood disorders and home-based oral and intranasal ketamine therapy as well. So what conditions does ketamine treat? Well, ketamine does treat a large number of mood disorders, depression, bipolar depression, treatment-resistant depression, as well as augmenting traditional antidepressant therapy. Especially when you first start off on specific antidepressants, you can use home-based oral and intranasal ketamine therapies to augment the effectiveness and outcomes of those antidepressants to make them work faster and better. Also, ketamine therapies work for anxiety disorders, post-traumatic stress disorder, obsessive-compulsive disorders, postpartum depression, and chronic pain conditions such as neuropathic pain, CRPS, cluster headaches, migraines, trigeminal neuralgia, post-herpetic neuralgia, as well as augmenting ketamine-assisted psychotherapy. So when people are stuck in therapy, ketamine, and especially oral and intranasal ketamine, can be utilized to augment those therapy sessions at the therapist's office. So how is ketamine administered? Well, we utilize it in a number of different ways. We use intravenous ketamine, which is the most effective and most rapid treatment. There's intranasal, racemic ketamine, and S-ketamine, which is Spravato. Spravato is the FDA-approved version of intranasal ketamine that's used only in the office setting. Then there's intramuscular injections, oral ketamine, sublingual ketamine, and of course, rectal ketamine as well. And I've shown a number of different formulations here. You can see ketamine RDTs up here on the left, and then you can see compounded ketamine bottle over here. You can use a MAD 100 nasal atomizer to help increase the amount of ketamine that is delivered and also increases absorption intranasally. And then there's, of course, IV formulations. And generally speaking, rooms such as the one set up in the right lower side here are utilized in a comfortable home-like atmosphere to increase the outcomes. Now, when do we consider home ketamine therapies? Well, we initiate home ketamine therapies for individuals who are initially starting their treatment for depression, anxiety, or their mood disorder. So individuals who have monetary disadvantage and just are unable to get the initial infusions, this might be an option for those individuals. Or if they have a milder form of depression or mood disorder, sometimes the infusions aren't necessary. And so we can utilize oral and intranasal therapies for the home front. But then also for maintenance therapy after the initial infusion series. Now, the initial IV ketamine infusion series are definitely faster and more effective to use infusions versus the home-based oral and intranasal, because you're getting 100% bioavailability with intravenous formulations. And the evidence has been very clear that the IV formulations work faster and are more robust. So if a person just starts off with the home-based ketamine and doesn't feel like they've gotten to that last bit of help, the intravenous formulation certainly can be the way to augment that. Now, we also use oral and intranasal ketamine for pain management as well. So that way people can lower their amount of pain medications that they use. And then there's also ketamine-assisted psychotherapy in assisting individuals with cognitive rigidity to increase their psychological flexibility. And, if they're having difficult conversations, they can actually augment those with ketamine. So ketamine should definitely be part of a larger lifestyle improvement plan, and basically things such as eating well, exercise, should be included, as well as a lot of self-care, and psychotherapy should always be part of the greater plan in individuals with any type of mood disorder. So the benefits of home-based intranasal and oral ketamine are fairly robust and clear. We know that ketamine is a rapid-acting antidepressant, and it has a robust effect in up to 75% of patients with depression who will either achieve remission or significant improvement in their mood disorder. And we know ketamine works in a number of different mental health disorders. We generally use ketamine initially as the IV racemic formulation. That's R and S ketamine. It's right-handed and left-handed forms, which are mirror images. Generally as 6 infusions over 2 weeks, usually 2 or 3 times per week at doses initially at 0.5 milligrams per kilogram over 40 minutes, escalating up to 1 milligram per kilogram through that period of time. And we just increase the dosing to help the individuals get the ultimate effect, which is remission. And then the maintenance after these initial treatments is always an issue. And the only thing really that lengthens out the effectiveness of ketamine infusions is psychotherapy, but also utilizing home-based therapies such as oral and intranasal ketamine can be options to help extend the time people don't need to have the booster infusions. But likewise, it also prevents that decline that some individuals will see at that 2-week or 3-week mark, so that way they can make it till their next infusion. So basically, we should also consider using intranasal ketamine and oral ketamine as an add-on treatment for depression, or as the initial treatment for depression. So when somebody comes in and starts Zoloft or Lexapro or one of those types of medications, we can initiate intranasal ketamine or oral ketamine to help augment the outcomes of those treatments. So what are the side effects of home ketamine use, or ketamine in general? We know that the home ketamine treatment is designed to be non-dissociative. So that means the trippiness really should not be the intended effect, but rather the neuroplasticity and maintenance. Really, the infusions are designed to provide the effective boosters in most patients, and the infusions themselves really provide the trippy effects, a part of the treatment where the individuals will have synesthetic feelings and psychomimetic type events. But the home treatment is really designed to be a sub-anesthetic, and also it is designed to be microdosed so that the individual really doesn't feel a whole lot of anything. And the majority of studies have demonstrated at lower doses that individuals don't feel any trippiness with the treatments. And so, although studies of low-dose ketamine use in depression haven't identified cases of dependence in an addiction format, there is a theoretical risk based on preclinical and clinical studies that show that individuals who use super high doses in an abusive form of ketamine can actually get tachyphylaxis, where basically they just get tolerance to the psychomimetic effects and also to the antidepressant effects. And these are in recreational abusers of ketamine. So we always have to have a conversation of use, an appropriate use of ketamine, as well as abuse and misuse of ketamine. So, as far as dependence, we haven't seen dependence occur in the ketamine use in depression trials. And when it's used in a prescriptive pattern, ketamine is actually quite safe, and so we can follow patients along. Now, we do know that there is misuse and abuse potential. The prescription is monitored, and it's given in therapeutic doses, and generally abusers of ketamine are using this in powdered forms mixed with other drugs such as MDMA and even cocaine at gram doses per day, the types of dosing that is used in anesthetic use. And that is a totally different situation. These individuals may be using them for months to years at a time. And so that said, in a prescriptive fashion, these are in the form of milligrams, maybe 50 to 150 to 200 milligrams per every other day, or a number of different options. But that said, generally speaking, ketamine abusers are using gram doses per day. And epidemiological data has noted that patients with no substance use disorder history are more likely to develop a substance use disorder when they have treatment-resistant depression. So treatment-resistant depression is a risk factor for substance use because opiates and sedatives are frequently leaned on by these individuals because of co-occurring anxiety, or the fact that they find opiates are very helpful as antidepressants for them, at least temporarily. So depression alone is a risk factor for misuse of substances that make you feel better. And obviously, antidepressants and treatments for depression make you feel better. So, the real question is the treatment, a problem or not? And that is obviously something that is monitored in the medical setting. So when we consider further side effects of ketamine use, we have to recognize that individuals who are using or misusing ketamine off the street are frequently trying to self-medicate themselves. And this is especially seen in individuals with depression or those at risk for depression who haven't received any treatment. So if you're depressed and you haven't received any type of antidepressant treatment or effective treatment, that was one of the risk factors for individuals seeking out things like benzodiazepines or opiates or other types of substances, including ketamine, to make themselves feel better. And so obviously in the general population, screening and management of depressive disorder should be really strongly considered and followed. And so we do see self-medication of ketamine in the general population, just like people will use dextromethorphan to self-medicate for depression in individuals who just haven't found the right treatment. So under this paradigm, appropriate treatment of depression with ketamine, when indicated, can actually reduce the misuse and abuse of substances such as opiates, benzodiazepines, and including ketamine used to self-medicate in this very population. So ketamine used at sub-anesthetic prescriptive doses doesn't have a true physiological withdrawal syndrome associated with it. And remember that psychiatric drugs such as Effexor and Paxil have withdrawal syndromes associated with them, and they can be quite severe. So depending on the dosing and absorption, some individuals, when they utilize the home ketamine therapies, may have some psychomimetic effects, but generally speaking, there should be minimal effective feelings when the individual uses intranasal or oral ketamine. So some people may have a slight trippy feeling. Some individuals may get some euphoria or enhancement of colors or perceptual changes, but in general, it shouldn't be that case. The dosing should be set up such that the individual really has a low perception of any enhanced feelings outside the treatment. Now, nausea and vomiting can certainly occur, and that can be prevented with medications such as Zofran or Phenergan. And of course, dizziness, coordination issues, and balance issues that may last a few hours can occur after use of home therapies. So individuals shouldn't drive for 6 to 12 hours after using these treatments. Now, there can certainly be some restlessness or anxiety after using the home-based therapy, just like the IV formulation. Most people don't get these symptoms, but occasionally it'll happen, and those usually resolve in a short period of time after the treatment is administered. And if you use the ketamine therapies a little too late in the evening, insomnia can sometimes happen, but for many, the actual treatment can be sedating. So again, it just really depends on the individual, about the timing with which they use it. But generally, this is a treatment that should be used at home. It should never be administered anywhere outside of the home front. And also, likewise, there shouldn't be any driving for at least a minimum of 6 hours after use. There can certainly be heart rate and blood pressure changes that can be very brief. No treatment is generally required. Individuals who are concerned over those types of issues especially should just check their heart rate and blood pressure on a regular basis and take their traditional medications. And certainly there's a continued list of other symptoms, just like with any other medication that some people can get. Although ketamine is used for headache disorders, some people will complain of headaches after using ketamine. Others will complain of just other unusual but minor symptoms that resolve quickly after home-based ketamine therapies. So oral ketamine is certainly an available option for home use, and there is evidence that IV ketamine is more effective than oral and intranasal ketamine. But we can certainly use oral ketamine as an option for treatment-resistant depression. But studies have demonstrated that its effectiveness is really seen somewhere around 3 to 4 weeks later after you initiate the treatment. So in this one study here with Dr. McIntyre's group, in their meta-analysis, they noted that basically the effect of ketamine by oral routes is really seen between days 21 and 28. So it's not as rapid and robust as other formulations of ketamine. And one meta-analysis by Nunez's group demonstrated the efficacy of oral ketamine in depression treatment, and they basically did a meta-analysis of a number of smaller studies and included 10 studies with 3 randomized controlled trials, and there were some 161 patients, and they noted that basically there was an antidepressant effect with oral ketamine in the second week, with response and remission rates being present. But they did notice that the number needed to treat for response was 3 patients. So basically, what this represents is that 3 patients effectively will get, out of every 3 patients, 1 will actually get response in terms of using oral ketamine, and for remission, out of every 5 patients, 1 will get remission, and that's actually a very high response and remission rate for a medication dosing. And also the dosing in these different studies that were evaluated was really variable, and the protocols were very different. So it was really difficult for them to kind of synthesize the data for oral ketamine simply because there were so many different protocols that were used. But again, the number needed to treat, was definitely a very low number. So again, number needed to treat of 3 for response, and number needed for remission being 5 definitely beats out a lot of the other therapies currently available. So we know that in further systematic reviews, that there have certainly been found oral ketamine to be effective and well tolerated. We know that there's low oral bioavailability of around 20%. So if you get 100 milligrams of oral ketamine, you're basically only going to get 20% of that. And so in this meta-analysis that we just discussed with Nunez's group, they noted that dosing strategies varied as much as 50 milligrams a day to 50 milligrams 3 times a day over a period of a few weeks, and that sometimes higher doses can be needed to achieve effectiveness. And so again, the data on oral ketamine is all over the place, but effect was definitely seen. But part of the problem is absorption, and different individuals absorb different amounts in different ways. And so again, you never can tell if an individual is going to respond orally to ketamine. And if they fail in an oral trial, it doesn't mean that ketamine failed them overall. Certainly intravenous and intranasal formulations are available, and the bioavailability is certainly a lot higher. So the other thing that we've noticed is that oral ketamine can be used to augment other antidepressant therapies. And in a double-blinded randomized controlled trial by Arbazadeh and his group, and this was in 2018, they took 81 patients and used oral ketamine with initial sertraline treatment. And they noted that individuals who had ketamine added to the sertraline had a higher improvement that was significant relative to the placebo group with sertraline alone. Some 85% of patients given ketamine with sertraline responded with antidepressant effect versus only 42% in the placebo group. And there were no side effects. So oral ketamine should be a consideration to increase the effect and power of a new antidepressant medication when it's added to your regimen. So, that's something which we use at Nova Health, is when individuals are started on a new antidepressant, adding an oral ketamine for home use to actually augment the effectiveness of that antidepressant treatment. Now, we know also that oral ketamine improves depression in chronic pain as well, and chronic pain and depression go hand in hand. So increased pain increases depression, increased depression increases your sensations of pain. And in a trial with by Jaffarinia and his group in 2016, they did a 6-week randomized double-blind controlled parallel group trial using oral ketamine treatment versus a placebo, which was diclofenac, and demonstrated improvement in depression scores and anxiety scores at 3 and 6 week post-intervention. So ketamine can augment not only pain relief, but also depression relief in patients with chronic pain. And further systematic reviews of oral ketamine for depression, as seen with Rosenblatt and his group in 2019, effectively they evaluated randomized controlled trials and several other studies of oral ketamine for its antidepressant effect. And these trials demonstrated that the depression severity changes were significant only after 2 to 6 weeks of treatment with oral ketamine. And again, they noted that the doses used in the trials that they evaluated in this meta-analysis were really variable, from anywhere from 0.5 to 7 milligrams per kilogram, either 3 times daily or once or twice a week or even monthly. And that basically it was difficult, obviously, to synthesize that data. But no adverse effects were significant. But yet there were significant results as antidepressant treatments using oral ketamine. But this was seen after about 2 to 6 weeks of treatment. So oral ketamine is a lot slower in its effect for depression. And oral ketamine has also been used in hospice patients. And so we've seen oral ketamine evaluated in a open label proof of concept trial in individuals who were in hospice. And basically 14 subjects with depression or depression with anxiety were given oral ketamine at 0.5 milligrams per kilogram daily over a 28-day period. And they measured a medically validated scale of depression and anxiety, the hospital anxiety and depression scale. And they noted that there were significant improvements in both depression and anxiety symptoms in individuals that completed the trial, and that there was a robust antidepressant and anxiolytic response. And so basically that they noted also that 100% of the subjects completing the trial responded to ketamine for both anxiety and depression. And generally speaking, the significant response to depression occurred by day 14, whereas the anxiety response started occurring at day 3. And so again, there were demonstrating a little bit of a delayed response for depression with oral ketamine, whereas the anxiety response seemed to be a little bit quicker. And likewise, side effects were few, mainly trouble sleeping and diarrhea. And this was in a hospice set of patients. So there was also trials demonstrating effectiveness of oral ketamine for chronic suicidality. And in a study with Can and his group in 2021, they basically utilized 32 adults with chronic suicidal thoughts and basically gave each of them 0.5 milligrams per kilogram of ketamine and titrated up to 3 milligrams per kilogram per day, and had follow-up assessments 4 weeks after the final dose. And utilizing the Beck scale for suicidal ideation, they noted a significantly reduced suicidal ideation tendency by week 6, and 69% of patients achieved clinical improvement in the first 6 weeks, and 50% achieved significant improvement by the follow-up at week 10. So 6 weeks of oral ketamine treatment led to a significant reduction in suicidal ideation. So this is the option for outpatient treatment of patients with just chronic suicidal ideations. And also, we know that oral ketamine can augment and decrease hospitalization in patients with PTSD and treatment-resistant depression. So there have been studies using higher oral ketamine doses for the treatment of depression. In one study with Hartberg and his group in 2018, they gave oral ketamine in the long term for patients with treatment-resistant depression. They reviewed 37 patient charts and noted that they had a 70% reduction in hospital inpatient days and a 65% reduction in hospital admissions when they were given oral ketamine on a long-term nature for their treatment-resistant depression and PTSD. And there were no long-term effects noted with ketamine. So this is basically demonstrating the use of oral ketamine to augment the treatment of patients who otherwise would be admitted all the time to the hospital for depression, suicidality, and post-traumatic stress disorder. And this treatment with oral ketamine actually allowed them to stay home longer and have better responses. So we know that also repeated oral ketamine for treatment-resistant depression outpatient therapy is effective from another study by Domani and his group in 2018. They used a randomized, double-blind, placebo-controlled proof-of-concept study and took 22 patients with oral ketamine and noted that there was a decrease in depression at all time points. So basically 27% of patients treated with oral ketamine achieved remission versus none of the controls. And the number needed to treat was 3.7. So basically, you get one success in 3.7 patients. That was an awesome result. And the dosing on this one again was 1 milligram per kilogram oral ketamine 3 times a week, and they did this for 21 days. That said, the results, again, were very effective, and the individuals had very few side effects. Now, there's also intranasal racemic ketamine, which can also be effective for depression and mood disorders as well. And we know that the absorption by this route is anywhere between 25 and 50%. And there's very little first-pass metabolism. And we also know that the peak norketamine concentrations, which is the effective part of ketamine, is actually very similar to IV formulations. So, intranasal ketamine is certainly a rapid way of administering ketamine to get it into the bloodstream without the liver taking out most of it. And we know that there were earlier studies by Lapidus in 2014 studying racemic intranasal ketamine for treatment-resistant depression. And in this study, 20 individuals were randomized, 18 completed 2 treatment days with intranasal ketamine at 50 milligrams or placebo of the saline solution in a randomized double-blind crossover study. And they noted that at 24 hours that the MADRS score as measured demonstrated that 44% of patients who were treated met response for a decreased depression. And that was compared to only 6% who had received the placebo. And there were minimal dissociative side effects. So at 50 milligrams of ketamine intranasally, there were minimal dissociative side effects, and also 44% of patients achieved actually depression response in 24 hours just with these 2 treatment days of intranasal ketamine. And they chose 50 milligrams of intranasal ketamine because it's similar to an IV dose that's measured between 0.15 to 0.34 milligrams per kilogram, which, again, is a little bit lower than what we would use as an IV formulation for IV ketamine treatment of depression. But on the other hand, though, this minimized the dissociative effect, and yet it still demonstrated that at least close to half of the individuals had response, and that was just with 2 doses. And evaluating a meta-analysis of multiple trials for intranasal ketamine in depression in adults, a group led by An and others in 2021 synthesized data in a meta-analysis format from 5 randomized controlled trials using S-ketamine and 1 using randomized controlled trial using racemic intranasal ketamine, such that a total of 840 subjects were treated. And this was then looked at in a number of different formats. And what they found was that individuals who were treated with intranasal ketamine, whether it's S-ketamine or the racemic ketamine, the relative risk of clinical remission was 3.55, whereas the clinical response was 3.22 at 24 hours. And basically, the pooled relative risk was 1.7 for remission and 1.48 for clinical response at 28 days, meaning that basically the odds were, threefold and higher that you'd have remission and threefold or higher that you'd have response at 24 hours using whether it's S-ketamine or racemic ketamine. Whereas also the risk of you having remission was over, 1.7, for at 28 days versus 1.48 for clinical response at 28 days. So it turns out that intranasal ketamine for depression, based on this systematic review and meta-analysis, can be an effective tool for the improvement of depression and allowing for both remission and response. And these were 5 of the trials that were included in this study. 4 of them were included with the S-ketamine versions of treatment, and 1 by Lapidus was R and S-ketamine, which is what we compound in a standard compounding pharmacy, and you're allowed to use that one in the home front, whereas S-ketamine is Spravato, and that one is only allowed to be used in the doctor's office with a risk mitigation program that requires the individual to stay in the office for 2 hours after its use. So basically, the treatment goals of home-based ketamine are basically to improve your outcomes and maintain your outcomes. And we know that there's S-ketamine, which is Spravato. That one has the risk mitigation needs that you can only use it in the office. You have to wait there for 2 hours after using it. It's generally done twice a week for the first 4 weeks and then weekly thereafter. And the benefit of home-based therapies are that you can use it at home in your convenience, and it's safe, it's effective, and the side effects are very few. We know that IV ketamine is costly and it's very effective, but it needs periodic boosters as well. And we can use oral and intranasal ketamine as part of the regimen for maintenance for the IV ketamine therapies. And this has been what we use at Nova Health Recovery as a way of people being able to manage their mood and depression and preventing that rapid fall off between booster infusions as they titrate and adjust their underlying antidepressant medications. And we do have specific monitoring rules for ketamine use at home for both oral and intranasal use. So it is written in a prescriptive fashion. Individuals use it only in the home front, and they can't drive for about 6 hours after using it. The dosing that we use is variable and it can change. It is based on the person's size and their needs. So it also depends on whether you think oral or intranasal ketamine. But these are microdosing, so the individual's not supposed to be getting a trippy feeling. They're not supposed to be getting psychomimetic effects. And generally, microdosing refers to the fact that the individual doesn't feel anything when they actually take the medication, much like microdosing mushrooms. With ketamine, the same thing. You're not supposed to have many effects or side effects noted instantly, but rather it's designed to maintain neuroplasticity. And the safety of these formulations of ketamine have definitely been shown in a number of trials, and some of them we've already gone through, that the majority of these trials demonstrated very few side effects. And that's what we see also at Nova Health Recovery, is that individuals who use these appropriately and again, we monitor every individual, that there are very few side effects noted. And that said, we do know that the individuals have great outcomes in terms of their mood with decreased depression, the maintenance of antidepressant effect of IV formulations, and also for pain management as well.